Hello, everybody, and welcome to BHCOE's monthly business development series. I can see there are folks who are joining us right now. So what I'd like to do is ask for you guys just to give us a little indication on the chat that you can hear me okay before we get started. So there's a chat window that you can put some information in there. And hopefully that's something that you guys can use. Perfect. I'm getting a lot of great yeses. Awesome. Well, thank you so much for taking the time out of your day to join us for today's webinar about CPT codes. My name is Sarah Litvak, and I'm the CEO here at the Behavioral Health Center of Excellence, and I'll be hosting today's webinar. For those of you who have yet to attend one of our monthly webinars, welcome. And for those of you who have attended others, welcome back. We're always happy to see that these webinars have been a useful resource for you, and we're really looking forward to continuing providing resources that are helpful to all of our members and non-members. Christine Ratcliffe is the one who curates the topics that are being discussed in these monthly webinars. So she is going to be putting her contact information in the chat window below. So if you have any suggestions or ideas for future webinars, feel free to reach out to her directly and she'll be able to add that to our list. For those of you who aren't familiar, the goal of the series is really to help you as business owners, clinicians, billing specialists, directors, supervisors, to access relevant information that can help you run your ABA practice in a more effective manner and more efficiently with an eye for ensuring continuous improvement. So today's webinar topic is highly anticipated as everyone has been anticipating the release of the new CPT codes by the American Medical Association. And as ABA services move into the medical model, it can sometimes feel like a moving target to know what's required of you and how to remain compliant. So thank you for joining us today. Just a bit of context for those of you who aren't familiar with the BHCOE and BHCOE accreditation yet. As we're waiting for folks to join, I'm just going to be spending a couple minutes giving you a couple updates just to make sure everyone's joined. So BHCOE accreditation is the only accrediting body that's specific to ABA organizations. And accreditation is an important oversight component that allows organizations to be held accountable to a set of standards in addition to the individual practitioner standards that the BACB oversees. So it provides a standardized peer review process for ABA organizations and allows them to benchmark their progress on things like patient outcome, turnover, staff satisfaction, and patient satisfaction. We take a lot of pride in the work we do, and I, along with our board and our subject matter experts work to create a BHCOE code that helps organizations positively impact their consumers. So our organization was created by behavior analysts for behavior analysts to ensure that regulation comes from within our field and that we stay unified in what it means to provide quality services. So if you're interested in learning more about our accreditation process, feel free to reach out to me or one of our outreach coordinators who I will be linking in our chat box, so you're able to contact them, or you can also fill out a submission form on our website and learn more about the process that way. And while I have you here, please take a moment to register for next month's webinar with Dr. Becca Tagg on reducing RBT burnout. I'll add to the link to the chat box after we're done here. And I think that it's something that is a definite topic that all of us are interested in. I hope that it's something that all of you will find value in as well. So please join us for that. It'll be fantastic. If you've ever heard Dr. Tagg speak before, she's a wonderful presenter. So as you're getting settled in, it looks like we still have a few folks joining us. So just a few other things to go before our presentation, before we start. The first is you will all be muted except our presenter and myself, and you will have the opportunity to send questions throughout the webinar. So we'll try and get those to you at the end of the presentation, but do feel free to respond to any of Jenna's questions because she does have access to the chat box. So if she asks folks, for feedback, then you're welcome to chat in there, and only she will be seeing your questions. There's also a separate Q&A box for questions, and that will only go to our moderator, so myself and Jenna. And if you'd like questions to be answered, just use that private chat box there, and at the end of the presentation, we'll go through those as we're able to. The next thing is that if you're interested in getting your 1.5 CEUs, you should have provided your CEU number at registration. And if for some reason you didn't, not to worry. You'll be sent a survey at the end of the webinar that will have a spot for you to add your BACB number so that we can provide you with your CE certificate. Please note we have a very, very large group today, larger than usual. So do allow a few weeks for processing before reaching out and asking about that. So the webinar will be recorded for those of you asking, and we do send the link of the webinar to anyone who's registered for the webinar. Another thing to note that if you are registered, it does integrate with our mailing list. So if you did register for this, you will be added to our mailing list. We send one email out per month that lets folks know about additional webinars. And if you don't want to be on our mailing list, just hit that unsubscribe button. We won't take it personally. But if you are interested, keep an eye out for some exciting topics coming up in the future, announcements about updates to the code, our disciplinary review processes, white papers, additional resources, things like that. Lastly, you can also find a recording usually about a week after the webinar in our virtual academy. So I'm going to link that in our chat box as well for you. And so just know that the virtual academy link usually comes up about a week after the webinar, if not sooner. But because this is such a hot topic, what I'm really hoping is that we'll have that up either today or by Monday, if not sooner. So, all right, I think we're ready to get started, and I hope that everyone has their lattes or their lunches as we begin the webinar, depending on what time zone that you're in. So first, I'd like to introduce our presenter, Jenna Minton. Jenna Minton is the president of Minton Healthcare Strategies, and MHCS was founded in 2013 and specializes in guiding clients through Medicare and Medicaid regulatory processes. Specifically, Minton Healthcare Consulting Strategies focuses on the development of current procedural terminology, or CPT codes, which are used to report medical, surgical, and diagnostic procedures and services. HCS also assists in valuing medical services through the American Medical Association's process, the AMA Relative Update Committee. And specialties Jenna has worked with include nuclear cardiology, otolaryngology, and applied behavior analysis. Jenna also serves as the Director of Operations at Residential Options, Inc., supervising 3 learning centers for autism in the mid-Michigan area. And she oversees audit, contracting, and reimbursement issues for ROI, which employs almost 400 people and services around 300 clients with ASD or developmental disabilities. Jenna is licensed to practice law in Maryland and is a member of the Maryland State Bar Association. She's a fantastic resource for our community and the perfect person to talk to us about CPT codes. I'll personally say that the amount of questions that she and some of the other committee members have received about this topic has been incredibly, it's been quite overwhelming. So if you've emailed her, if you have questions, please know that she's dealing with hundreds of them and that she's working her way through them. So just be a little patient with that. And if she does respond to you and you had some follow-up questions, then she will have to come back to that a bit later. So we're very grateful for all the work she does. And with all that being said, Jenna, the floor is yours.
Wonderful. Thanks so much, Sarah. I really appreciate that nice introduction. Let's see if I can grab the screen here. Right. Can everyone see slides okay?
They look good to me, Jenna.
Okay, wonderful. All right, well, thank you again for the warm welcome. It's great to be speaking with everyone today, and it's very encouraging to see the participation that we have. I know that coding can sometimes be viewed as a little bit more of a dry subject, but it's wonderful to see that you all know that this is important information for you as a provider or your practice if you're a practice manager or coder or biller. It's really important for us all to be on the same page and have this as we head into the new year with a new code set. So kudos to you for taking the time to dial in and be up to speed. So just an overview of what we're going to talk about today. We're going to discuss what CPT codes are and how they're developed. Once a code exists, how might it be valued? The thing everyone wants to know, if you haven't already seen them, what are the new codes? What's the content? How are they structured? And then the most important piece really in terms of education and preparation over the next few months heading into the new year is how are we supposed to prepare for this new implementation and work with our payers. Sarah did a great job of going over my background and disclosures, so I'll just pause for a second. Always want to make sure I show that slide for transparency. But I have had the benefit of being able to work with some wonderful groups, particularly in the ABA field, and continue to do so. And that those groups comprise, we'll talk a little bit later, our national steering committee that really should be credited with the work that has been going on the past few years. And so we'll be talking about what those efforts have entailed, but really kudos to them for working on your behalf as a community and ABA community to improve these codes. So what are CPT codes? Hopefully we know this, but if not, it's a good place to start. CPT stands for Current Procedural Terminology. It's a listing of descriptive terms and identifying codes for reporting medical services and procedures. There is a link here to where you can purchase a CPT book or other CPT resources. They are owned and copyrighted by the AMA, which is noted there at the bottom of the slide. So it is their property. It is not ours to redistribute or share. So I receive no benefit, I always say this in my talks, from the AMA for people purchasing their products, but it's important for you to have the correct, accurate information in your practices to report services correctly. So the purpose, and Sarah did touch on this, of CPT is to provide uniform language. So we're all saying the same thing that accurately describes healthcare services in order to foster both consistent communication among healthcare providers, but also between patients and providers and third parties such as payers. Who can request new codes? Truly almost anyone. Often it is medical specialty societies that share those efforts, but an individual practitioner, provider, hospitals, third-party payers, or really any interested party could submit a code change application for consideration by the CPT Editorial Panel, which is the body within the AMA that reviews code change applications and approves and oversees the development and updating annually of the CPT code book. The AMA's CPT staff reviews all requests to make sure that it's not something that's already been addressed. If the application does in fact represent a new issue, it would then be referred for evaluation and comment at a CPT editorial meeting. An open comment period then follows, in which the CPT advisors and any interested parties from the public can submit comments and questions on the application. And if in fact a code change application does not receive any support during that open comment period, the person who had submitted it or persons would be notified and they would have the opportunity to withdraw prior to the meeting if they chose to do so. The CPT cycle includes 3 meetings a year. During these meetings, which are in person and they rotate around in location across the country, a large number of folks sit in a really big room and they review the applications one by one, and they have primary reviewers assigned to them who are supposed to be experts on the content of that particular application, and they present a little synopsis initially and put the item on the table for discussion. Presenters are there, the submitters of the code change applications themselves, to answer questions and try to help the panel understand what the request is all about. Those applications are due approximately 2 to 3 months in advance of the actual meeting, which allows time for the process I was just describing on the prior slide for comment and review. And again, the submitter does receive those comments in advance. So what are the potential outcomes of the CPT panel meeting and a code change application request? I've sort of drilled these down to relatable buckets, but I call the first the I win. This is the ideal scenario, of course, where we submit an application and either with some minor revision or no revision, the panel decides to approve the request for new code or revision of existing codes. In that event, the change then appears in the forthcoming volume of CPT, which, as many of you know, is updated on an annual basis, and typically the code change or the code books come out with changes in the fall prior to the year of implementation. So we just had the codes released for 2019 here this past week. We have the maybe scenario where the panel has additional questions and they refer the topic to a work group for further study. We have the try again, which is postponement to time certain. That would be a future meeting, and that would be a situation where the panel says, we need specific additional information in order to reconsider this application. Or the sorry, Charlie, which does happen, where they just flat out reject the item, whether it's there may not be enough literature to support or they don't feel there's widespread use. There's many metrics that they utilize in order to make these decisions. So the types of CPT codes, this is really relevant for today because this is a significant change going into the new year. So we have the Category 1 codes, which we now have. These codes are numeric and 5 digits long. They are divided into the 6 sections that you see there in the code book. I have medicine colored and underlined because that's the section that our ABA codes are found within. And this is critical. These are permanent codes, which means that they are accepted by CMS, the Centers for Medicare and Medicaid Services, and other third-party commercial payers. Our prior code set, the T codes, as many of you know them, are Category 3 codes, which means that they are temporary codes, and they are used to allow time for data collection for services that are considered to be emerging technology. And they're intended, to substantiate that widespread use, and that is a term of art from CPT, and essentially means that they're sort of in a test phase. We're monitoring their use to see if this is something that is going to stabilize in terms of volume, but also to allow the literature time to catch up and to be robust enough for them to be considered eligible for a Category 1 status. So once I have a code, how might it be valued? There are a couple of options here. They can be valued, as Sarah noted, through the AMA RUC process. That is done utilizing a survey, and I'll talk a little bit more about that. They could be valued through rulemaking. That would be where CMS decides to assign values and then publishes that in the summer for notice and comment by the public, and then either tweaks or finalizes their proposal in the fall of each year in the Medicare Physician Fee Schedule rule. Or they remain carrier priced. That would be a scenario where CMS does not set a value, there is not a RUC survey, and all payers determine their own reimbursement rates. Carrier priced is what the T codes currently are, as you probably are aware. And so just to give you some context for that term. What is the RUC? It is a unique committee of representatives of major medical specialty societies. Their work is dedicated to describing the resources required to provide physician services, which CMS then considers in developing relative value units for billing codes. They do this, as I mentioned, through a standardized survey tool that's sent out by all medical specialty societies. Everyone utilizes the same tool. Or other professional organizations recognized as stakeholders by the AMA, who members are familiar with the services being valued. So we don't have every medical specialty society surveying every code. They want the experts, obviously, giving them the information on what the work and time involved is. So there is a process by which specialties can designate if they think their members have expertise on things that are eligible for review. And then those identified experts would be the ones leading the survey effort. It's important to note that at present, no behavior analysis organizations are recognized as stakeholders. They do not have what's called a seat on the AMA RUC or CPT editorial panels. And there are some pretty rigorous requirements for obtaining a seat. It's not like you just apply. There are several conditions that the AMA sets forth in order to do so. Although the RUC does provide recommendations, so after the RUC survey goes out, the results are collated, the RUC panel meets in person, they vote, they decide recommended values, those get packaged and sent to CMS once a year for inclusion in rulemaking. CMS can say we agree or we don't agree. They make all the final decisions about Medicare and Medicaid payments, and again, those are released twice a year via that MPFS rule. Carrier pricing. CPT codes are carrier priced, as I said, when a survey is not completed or when CMS decides not to assign their own value through rulemaking. That can happen for many reasons. First, if the specialty does have a seat and can participate in the RUC process, there are survey response thresholds in order to have the RUC actually value your codes. So if a specialty doesn't feel they can obtain the adequate sample response size, which ranges depending on the use of the services nationally, from a minimum of 30 responses to a maximum of 75, they might elect not to conduct a survey. Second, the specialty, again, may not have a seat and therefore they cannot sponsor a survey. And then third, perhaps the specialty has decided that they think carrier pricing is a better route for the field or for that particular family of services. And so they elect to just not conduct the survey. How does carrier pricing work? Specialties or individuals can inform CMS valuation by submitting information and recommendations as part of the notice and comment of the physician fee schedule rulemaking cycle. If the valuation information is not received at all, if no one makes suggestions to them or CMS decides that they don't like the recommendations they've received, they can decide to allow the codes to remain carrier priced. Depending on the valuation outcome, some commercial payers may or may not be likely to follow suit. So even if CMS decided that they wanted to assign values to our codes, for instance, that doesn't mean that payers have to follow suit and publish a fee schedule that mirrors what CMS has done. They often do, but that they are not required to. Where have we started? So going to our codes and sort of the background and process, the evolution of how we've gotten where we are today. So many of you know that in 2013, May of 2013, the initial code change application was submitted to the CPT panel by ABAI. And the reason it was submitted was to address inconsistent coding and reimbursement for ABA services by payers across the nation. At that May meeting, the panel decided that they were not able to put through the code change application at that time, but preferred that a work group be formed to evaluate the needs of an ABA code set. And that consisted of representatives that submitted the application itself, but it also required inclusion of groups like psychology, speech language pathology, OT, psychiatry, pediatrics, and more. I think that group of specialties was actually upwards of about 12 organizations. In the very next meeting, October of 2013, that work group that was required to be convened submitted a revised application, and the Category 3 codes that we have come to know, the T codes, were approved. As you know, they are under the heading Adaptive Behavior Services. They took effect in July of 2014, and ABAI pretty much immediately conducted a survey of providers to garner input on that code set, and were informed pretty quickly, I think, that there were concerns with the structure of the T codes. So in response to that, in 2015, an ABA services work group, this is a different work group, not the CPT required work group, but a work group was formed to develop a proposal to modify the Category 3 codes and convert them to Category 1 codes. So that was the main focus of this group. The group has a steering committee, which when I say steering committee, whether I'm emailing with you or in this presentation, these are the folks that I'm mentioning. So the steering committee is comprised of representatives of 4 organizations, including ABAI, APBA, the BACB, and Autism Speaks. I support their efforts as their CPT consultant, but the steering committee is a component of that broader work group, and the work group was really very critical to informing our efforts over the past several years. That included ABA providers. We tried really hard to include folks from small, medium, and large practices so that we had a broad distribution of input and perspective, as well as consumers, advocates, and representatives of several health plans, which was also very helpful. We also sent a survey, I'm sure many of you received it, and many of you participated, to over 30,000 ABA providers to collect information on your usage of the Category 3 codes, potential limitations that you saw with them, challenges, questions, opportunities for improvement. We compiled all of that feedback and then saw input from the CPT Editorial Panel staff, those professional societies we mentioned that the AMA had required us to engage as stakeholders. So, taking all of that wonderful information into account, we worked tirelessly to submit a revised code change application, which was submitted in October of 2016 and presented at the February 2017 CPT meeting in San Antonio. Representatives from the steering committee organizations were all present for the presentation and to answer questions. The application included, obviously, a revised code set, rationale for proposed revisions, vignettes, and descriptions of work for each code, evidence review, policy statements, guidelines from professional societies and payers, and descriptions of the types of providers. This is an area where the medical model and the medical community really gets pretty confused pretty quickly about who's doing what in the services that we provide, and so clarifying that was a key component of this effort. The key things we tried to address based on all of your wonderful feedback over the last year and a half or so. So first and foremost, we hear you loud and clear. Add-on coding structure is really challenging and very confusing. So that was certainly something that we wanted to simplify and streamline. Challenges with the 30-minute increments for codes. I think a lot of folks back when payers were using the HCPCS codes or some kind of a blend were maybe a little more used to a shorter increment of time. Uncertainty about how to code and report supervision. I have that in quotes because in the new codes, we'll talk about this probably extensively here in the near future. That term has sort of been replaced with direction of technician, but how to report that work by the behavior analyst. Uncertainty about how to code and report indirect services in time, which is something I know we'll be talking about also. I'm sure you'll have questions. Confusion about differences between group work and social skills, and then confusion about the assessment coding structure as a whole, what that pesky term exposure is supposed to mean. So where are we? The outcome of the February 2017 CPT editorial meeting, as you now know, resulted in 8 codes being approved for Category 1 status. We have those code numbers now. We know that they're 97151 through 97158. We have 2 modified codes that are going to stay Category 3 for now because we felt that the widespread use and literature levels were not quite where we needed them to be to attempt to elevate them. And those are 0362T and 0373T, which you know are in the existing T code set, but again, they have been pretty significantly modified, hopefully clarified for folks going forward. And all the other Category 3 codes will go away effective January 1. So when codes are elevated to Category 1 status, their predecessor Category 3 code is what we call sunset at that time. So what does it mean to have a Category 1 code? As we talked about, the Category 3 codes are temporary, and they signify only that there's some evidence of clinical efficacy and of evolving clinical utilization. These Category 1 codes that we now have are permanent, and they signify that clinical efficacy of the services has been documented and meets the rigorous AMA standards. The services are also performed by many folks, and they are consistent with current medical practice. So for the 8 codes that now have that Category 1 status, we should be expecting a more uniform and consistent adherence to the descriptors as approved by the panel, and that's across providers, it's across states, it's across payers. And then a very, very positive trickle-down effect of obtaining that Category 1 status is fewer denials based on rationale from payers such as this service is experimental, it's unproven, it's not medically necessary. Now that we have these permanent codes and robust literature to support, the hope is that any kind of denial for those reasons would be virtually eliminated.
Jenna?
So, yes.
I'm getting a couple questions about whether the codes are mandatory for payers.
Yes, so I am also getting a lot of those questions. The answer is yes, under HIPAA, under the HIPAA statute, if a payer accepts electronic submission of claims, they are required by statute to implement Category 1 CPT codes. The caveat to this is that that's going to take time. So as we get into kind of the implementation process, I'll be talking a little bit about this in terms of what you can expect, but just because it's, quote, mandatory does not mean that you should expect on the first of the year everybody to be ready to roll and utilize these services. So I think the key here is, yes, we are all working towards that goal and they are required to work towards that goal. That doesn't mean they can't supplement with HCPCS codes for things they don't feel are captured within the new Category 1 codes, or that they can't have what I'll call a more drawn out implementation process. All
Great,
right.
thank you.
Sure. So I just like this little guy and his funny face. But the summary of what we've just been talking about is to elevate the codes to Category 1 is a big deal. It should be. I know change is always hard, but it should be a change for the positive once we've sort of all gotten on the same page about what steps we need to take to implement them. So I'm hoping that this is showing up clearly for everyone and all the text is on the screen. It's a little funky for me. So let me know if you're having trouble seeing this. But here are our codes. I have broken them into some buckets of type of service. So here to start, we have the 3 streamlined assessment and reassessment codes. The first code, and apologies, I need to take the X's out of these. So 97151 is our basic initial assessment and ongoing reassessment code. This is conducted by a physician or a qualified healthcare professional. You can see that all of our codes over here are per 15 minutes. And you can see over here we do have, and hopefully this is pulled right from the chart that was distributed earlier this week by all of the steering committee organizations. And so hopefully you have seen this. If you haven't, please let us know. We want to make sure that folks have this in their hands. But hopefully this column is very helpful to clarify who needs to be present at when these services are being reported. So again, this is our bread and butter assessment reassessment code. It does state very clearly here, I've gotten a lot of questions about indirect time for assessments in particular. Those services are included. So this code captures the dates that you are face-to-face conducting your assessment work, as well as the dates where you're not face-to-face, and you're analyzing past data, you're scoring and interpreting the assessment, and you're preparing the report and the treatment plan. We then have the supporting assessment codes, the 97152, and then our revised 0362T. You'll notice that this first supporting assessment code is by a technician. I've gone ahead and underlined the person delivering the service for purposes of today's discussion. And so this is all face-to-face time with the patient, and it is under the direction of a physician or qualified healthcare professional. So that means that, no, this is, someone asked me a great question last night about, so is this really within the technician's scope of practice? Are they just going in and doing an assessment? That doesn't seem right. No, that's not what we mean here. This is a situation, these 2 codes capture our FBAs and our FAs. And they're not limited to that use, but this is a scenario where, based on the initial assessment or reassessment by the QHP, we need more information. And so the QHP has decided what supporting information they're looking for, and then gone over that with the technician, and the technician is the one doing the face-to-face probing with the patient. Again, the 0362T code here is another form of supporting assessment, but this is where we need more than 1 technician. So we have a minimum of 2, but it can be more. This is administered by the QHP who is on site. I'm going to read you the definition of what on site means. which is that they are immediately available and interruptible to provide assistance and direction throughout the performance of the procedure. However, they do not have to be present in the room when the procedure is performed. So that is required for our Category 3 codes, both assessment and direct treatment. These are our patients who have pretty destructive behavior and need to be completed in an environment that's customized to the patient's behavior. So that can mean a lot of things, as many of you may have encountered with the current exposure codes. Payers got really stuck in some instances on some of the language in the CPT Assistant article surrounding padded rooms or two-way hand radios. And so we really attempted here to clarify that, yes, customization for response to the patient's behavior, and that may be safety, but it may be other things, is required for the use of these services, but it doesn't only look one way, and it can happen in a variety of environments so long as all four of those requirements or bullets are met. Moving on to our treatment codes.
Jenna, really quickly, let me just pose a couple assessment questions to you. One of them is whether you can bill 97151 and 97152 at the same time if both the BCBA and the RBT are there.
And I would say no. So these are not concurrent services. They are intended to be the behavior identification assessment. So the 97151 code, it occurs first. And if you need additional information to supplement and help you complete that report and treatment plan, whether it's an initial or an update, that's when we go to the 97152 or the 0362T codes.
And does 0362T require a specialized environment?
So that's our fourth bullet there, where the environment needs to be customized to the patient's behavior, whatever that particular patient may need. So I'm going to give some examples. These are not the only examples. Please hear me clearly when I say that. But so for instance, possibly a padded room, possibly a room with no materials at all in it, depending on, if the person has pica, you want to make sure that the room is void of anything that is dangerous in that regard to them. So it can look a lot of different ways.
Great. There's quite a few questions and we can't get through all of them right now, but just know that at the end we have about 25 questions that are pending in the queue. So
sure.
We'll get to these at the end for everyone who's asking. Okay.
Moving on to our treatment codes, 97153, 97155, 0373T. So our first code here, again, we've got the service provider underlined, is that direct one-on-one treatment by a technician face-to-face with the patient. And I want to make clear, you can see in the far column on the right, for the technician codes, the codes that have technician written in them, that doesn't mean that that the QHP can't provide those services or report those codes. They can be a substitute for the technician, but often you're going to see payers wanting you to use a modifier of some kind to indicate a higher level service provider. That may mean you have a different rate in your contract, depending on whether it's a technician that's providing the service or the QHP, but I just want to point that out. It could be either delivering the service. The 97155 code, so in this case, this can occur in two scenarios, and I want to carefully cover this. This could be the QHP directly providing the one-on-one treatment. It can also be the scenario where the QHP is coming into the room, the technician is there providing the one-on-one treatment, and the QHP is directing the technician face-to-face with the patient. So that's, back this old term that many of us still use of supervision. This is where that concept comes in. And I want to be very clear that 97153 and 97155 can be reported together as long as the patient is present. If it's a scenario where I, behavior analyst, am sitting in my office with you, technician, and there's no client present and we're just discussing the case, or discussing something that we're looking to possibly change or reevaluate with the programming, that kind of, quote, supervision is a non-billable activity and is not captured by the codes. Our third code here, 0373T, is again our multiple technicians required to deliver that well, it's not one-on-one, two-on-one or more treatment. And our four metrics or our four components are the same as we saw with the assessment code down here. So again, the QHP must be on site, immediately available, but not necessarily in the room. Two or more technicians, exhibiting destructive behavior, and then that environment that's customized to the patient's needs. Moving on to our group codes. So we have streamlined this as well. We have removed that social skills code. There was just a lot of confusion about what's the difference between group codes and social skills codes. And to be frank, we really weren't sure that there was a need for all three. And so you see here that we've tried to streamline and reduce down a bit. So our first code is when the technician is administering the group treatment. And this again is face-to-face with two or more patients. There are parentheticals in the code sets for all of these group codes that do limit the group size to 8 per technician or per provider, depending on which code you're using here. And again, we still have the 15 minutes, so we've got our 97154, our 97158. 58 is to be reported when it's the QHP that's conducting the group treatment. And then last but certainly not least, our family codes. So we have our family treatment guidance code 97156. This is a scenario where the caregiver is face-to-face with the QHP. This can be with or without the patient, and I think that's really important. You can see that in the parentheses here. That really should be driven, obviously, by medical necessity. If you're trying to teach the caregiver something or model something that requires the patient to be there, certainly you would want to be reporting the service that way, but sometimes it may be more appropriate for the patient not to be present. Perhaps you don't want them to overhear certain discussion or things of that nature. And so just to be really clear, this can be either scenario, but you and the caregiver or guardian do need to be face-to-face. I do want to give one caveat to all of that because I've gotten a lot of great questions about this as well over email. The whole notion of telecommunication and whether we can do family trainings over Skype or some HIPAA compliant, FaceTiming mechanism, that is up to payer policy. So CPT does not prescribe whether or not that is an acceptable means to utilize the codes. That's a payer policy issue. So you need to look to your contracts or your provider manuals to guide you on whether or not face-to-face can be met, that requirement can be met through telecommunication. And then last, we have our multiple family group code. So this is administered by the QHP, and in this case, our patients are not present. We are face-to-face with multiple sets of guardians or caregivers. And again, that group would be capped at 8 sets of guardians or caregivers. Some important differences between where we've been and where we're headed would be that we got rid of the add-on codes. Hopefully people are doing a silent cheer on your end of the phone. So we've dramatically reduced the code set by virtue of eliminating that coding structure. We're down to 10 versus where we were with 16. We have streamlined the times of the codes, so we don't have some encounter, some 30, some 60. Everything is 15 minutes in increment. We do not have codes for indirect services because CPT doesn't allow it. But I do want to just reiterate what we already talked about, which is that there are codes that have very clearly both face-to-face and non-face-to-face work, in particular that assessment and reassessment code built into them and in the code descriptor itself. So steering committee efforts, what have we been doing and what are we doing to try to help you prepare? I've talked a lot about some of this, so on this particular slide I'll try to move through, but as I said, I really hope many of you have laid eyes on that coding conversion table. It was sent earlier this week. Please let us know if you need access. We've surveyed all of you many times trying to get input to make the best revised code set we could. We respond to countless member and constituent inquiries. In particular, as Sarah mentioned, right now I'm getting to talk to lots of you, which is wonderful. Presentation of coding updates. We are trying to hit every national meeting with someone from the steering committee possible to continue education efforts. We have been distributing and will continue to do so updates on the process and what's coming next. We've led a pretty concerted effort to correct medically unlikely edits and NCCI edits to rectify some payer policy issues. They were capping codes at clinically inappropriate rates based on flawed CMS new edits for the Category 3 code set. Development of implementation resources, which we're going to talk about here in a minute, to help you navigate what's coming. And then we have been working with the AMA to revise the 2014 CPT assistant article on the code set. Our hope is that that will be published this fall before the codes take effect. But as you probably know, payers really look to that CPT assistant article and the AMA's publications as their Bible, so to speak, of how to use these codes and how they're intended to be reported and what boundaries, if any, to put on them. So it's really important to get that article right, and we've been working on that, as I said, the last few months. So what's coming and what should you be on the lookout for? We are working on a payer packet that is in production. That updated coding conversion chart was released this week. The things that are in queue and coming next will be a template letter to your payers announcing the release of the new code set, requesting timelines and process for implementation, asking questions about what their intention is for converting authorizations. Will that happen in bulk? Will it happen as reassessments are required to come through or some other process? So be on the lookout for that. That's a really important one, and I encourage you to send that to your payers once you have that resource. Evaluation crosswalk table. So this will assist with payers who might require that we both document our work using the correct code from the ABA code family, but that we also provide what they call a crosswalk, which is a code within the Medicare physician fee schedule that has been valued. So we are expecting these codes to be carrier priced in 2019. And so some payers, when codes are carrier priced, do require a crosswalk comparison to also be included on the claim. And that would be like services with relative value units that would establish code reimbursement. And so there will, I know that that's a very brief summary of a very complicated concept. And so just the bullet there, it will include instructions and information on how you use comparator codes, what relative value units are, and what that process might look like. And we can certainly help one-on-one with guiding you in that if in fact your payers require it. Many will not, so I don't want folks to get too worked up about that right now. Let's focus on notifying our payers and what implementation will look like. So what should we be doing to prepare? Obviously, education is key within our community and within our payer relationships. We need to first let them know that they're coming. You'd be surprised. You think that maybe they would get some kind of a bulletin from the AMA, but they don't. And so it is on us to make sure that we are communicating well with each other and letting them know that new codes are available. Using that code conversion table and other resources to work with your payers to achieve consistent use of these codes. If you haven't already, giving the BACB's ASD treatment guidelines and APBA's white paper, identifying applied behavior analysis interventions to your payers to try to educate them, and then obtaining accurate MUs, so making sure that they have implemented the correct MUs, which came out last October with corrected levels, and that you're able to report these codes as medically necessary and appropriate depending on your patient. Additionally, we should be reviewing contracts. I know that's not a very exciting proposition, but it's critically important for you to know what you've signed on to. So knowing your payer policies, knowing that your contract isn't limited to the four corners of that agreement. There's often a very lengthy provider manual that the big payers will utilize, and that's really where the meat of how they view behavior analysis services is going to be found. So it's really important to make sure you have both of those resources available to you. Knowing what their requirements for medical necessity and coverage of ABA services are, as well as what they're required to do if they're going to modify your agreement. So that's part of this letter, letting them know new codes are coming. It's not just how are you planning to roll them out, but also amending our agreements and what kind of notice period are they required to give you. It's important for you to know all of that and be prepared to hold them accountable if they're not meeting the requirements of your agreement. Compliance with contract provisions and payer requirements regarding how you're documenting your claims is essential, especially in light of the recent billing fraud cases and heightened scrutiny. So it's really important also to make sure we're documenting properly and following their requirements. Again, probably called out more clearly in that provider manual than your actual contract. Asking questions, so engaging someone who's knowledgeable to help you. We are going to put out as many resources as we can, as fast as we can to assist, but making sure that you have the resources available to you to do this right and communicate effectively, particularly in understanding the new codes, which is why you're all on the phone today. So kudos to you, this is a great start, but also things like implementing them into your EMR. I mean, just reaching out, and I know there's a lot of new EMR products out there for ABA specifically. And so working with those folks to notify them that the codes are here, asking them for their timelines of when you can even get them in your system and have them available to you. If there's going to be a delay on their end, communicating that back to your payers. And then preparing for a potential disruption to revenue. So any of you who provide ancillary services in your practice know that as codes change and are modified and EMRs are modified, the payers also have to get these codes into their systems. And so that's where the implementation timeline questions are really key. We want to make sure that if there's going to be a testing period where in the background they are testing claims and batches of claims with the new codes, but still asking you to report the existing codes until the testing period is over, that you understand if that has any impact or not to timeliness of receiving payment and so forth. Last, we really need to know our own information. It's critically important that folks are calculating on their end the value the rates, the value that you need to be receiving for your services and your time. And that should not just be face-to-face, I pay my technician X, and so I need to make that exact same amount in order to cover my costs. No, we are missing a lot in that model. So consider everything that you need to provide these services: overhead, practice expenses, technology, liability insurance, etc., including services of both the technician and the behavior analyst for codes that involve both people, not setting, so to speak, that flat rate that may really be missing the mark in terms of making your business viable. Using the resources available, but really want to encourage folks to do their own homework. You really need to know your own data. You need to know your practice expenses. I think sometimes it's easy to forget to include all of the things that we have around us to help us do our jobs. And so really making sure you're doing an independent evaluation of that, and that we're being respectful of antitrust laws as we're picking each other's brains about some of these topics. And then last, I can't encourage this enough, negotiate. I know it doesn't seem like it, but truly the rates in your contracts are always negotiable. And so even though this might be scary as a change, I just want to encourage folks that this is also an opportunity. If you have rates that you realize now are not sufficient, this is an opportunity to provide them with data about why they're not sufficient and hopefully renegotiate that as they implement the new codes.
And Jenna, we actually have a webinar on negotiating rates, so I'm going to link that in the chat for those of you interested in that.
Wonderful. Okay, so enough of me.
Questions. Okay, so that was wonderful. Thank you, Jenna. I know that it's a cursory overview and there's only so much you can get through, and you could probably spend 30 minutes to an hour on each of those codes answering questions specifically. So for those of you who are tuning in, we do have about 75 pending questions. So just know that what I've been trying to do as you're asking them is group them by topic. So I'm going to try and get through the general topics that I'm seeing out there. But Jenna, if you have access to that chat window too, you can certainly take a look as well. And that might give you some good context for what's happening. So some of the questions I'm seeing is related to the assessment code first, which is, first, is there a cap for units? Or do you think there will be capped, like you can only do it one time per year? Or what do you do if you need to do a second assessment? How would that work?
Sure, great question. So again, a lot of what you're going to ask me today, I'm going to say is up to payer policy. I promise you that's not me passing the buck. It's just honestly true. So yes, I'm sure that many payers, just as they do now, will implement, which they absolutely have the right to do, certain caps on services. And so if there is a MU, a medically unlikely edit out there from CMS, that is the national recommendation for a cap. I can work with Sarah to link folks to the file so that they can actually see what the current Category 3 code caps are. I would expect that payers will just map those over, but I can just speak to some of the trends that I see. I have seen a 4-hour cap on an assessment, 6 hours, 8 hours. I have not seen a whole lot of payers that are allowing above 8 hours total for assessment work, but that doesn't mean that they don't exist. These are going to be key things that when you're seeking those initial authorizations, those are things you're going to need to be asking. And if you have a patient that needs more time or has a unique scenario, certainly don't just take the flat payer policy and say, okay, well, even though I need significantly more, this is what they said, so that's what I'm taking. Have that conversation with your customer service reps and work hard to try to negotiate what you need.
Great. So the next question, and there's quite a few of these. So I think the general question is about the concurrent billing. And I think maybe what we'll get at this question is, how do you know whether the code can be billed concurrently? I think it's important for everyone to understand that. And then when it says like a tech and supervision can be billed concurrently, do you mean both the BCBA and the BT can be billed when they're in the same session together? Or, can you just clarify how we know that's the case and who are those folks who can bill together?
So without specific scenarios, that's a little bit hard for me to give you a very specific answer. But the first thing that I would point us to in terms of who needs to be present is this face-to-face language. If the code says face-to-face, then you need to be in the room unless it says specifically, as the 151 code does here, that it also includes non-face-to-face work. The time that you're reporting, so every 15 minutes, needs to occur when you are in fact face-to-face. So if it's that 97153, 97155 scenario where the BT is running the session, that's a 3-hour session, and the QHP comes in for an hour to direct the technician and model and modify the protocol, etc. You're billing for an hour of that QHP time with that 97155 code, but you're billing 3 hours of the tech time for the 97153 code. Does that help?
I think so. I guess the viewers will decide, but I hope that provided some clarification. And if someone wanted more information about those guidelines for billing concurrently, is there a resource that you can point them to, or where can they learn a bit more about that?
Honestly, the best source is the CPT book itself, because the parentheticals under each code, which are not reflected in this chart, are where they literally spell out for you, you may report this with this, you may not report this with these. And so it's really critical that people do have access to those resources.
Okay. And then in terms of how we know that it can't be billed concurrently, would that also be in the code book, or is that contract specific?
Both. So yes, the parentheticals do have restrictions, and they will tell you what can't be reported together. But I also would definitely look to your contracts, because payers will outline their own policies in some cases if they feel it's unclear. I also would really pay attention to the attended by column that we've been looking at, because that's going to tell you who needs to be in the room, who needs to be meeting this quote face-to-face requirement to report the service.
Sure. Yeah, and I think the billing concurrent component is something that makes a lot of folks nervous because obviously a lot of models are built off the fact that you can. So if there's
Right.
any changes there, that could impact them. And then what about things like graphing data or updating programs or, reporting while the client is present, for example? Would that be covered then as well?
So treatment planning programming is not a billable service. It is an indirect service that is considered bundled with all of these activities. So having the client present in order to be billing that makes the face, it meets, and supposedly, in theory, you're thinking the person is here, so I'm meeting the face-to-face requirement. I would say that in terms of how the codes were structured, that we would probably not agree. The goal is for those non-billable activities, those bundled services, is to be negotiating rates that pay you for both your face-to-face time. So you're going to have programming changes you need to make, right? After you've looked at the data from the technician being in a session for however long they're in there with the client, or after a week of those sessions being conducted. And so that time, even though it's not during the session or necessarily with the patient present, you're wanting to make sure that your rate for those direct services is sufficient to capture both your time doing the treatment planning whenever you're doing that and covering the cost of the person's time and effort delivering the face-to-face service.
Okay. Great. So let's see what other questions we have here. Anything you can tell us in terms of that transition? So will the old codes still apply? How long will they be around for? Will they still be used even though we have these new ones? And what would that transition look like?
So that's where this letter that is going to be the next resource that will be distributed broadly is really key. So those are the questions that we'll be asking payers. I think some of our bigger payers that are more savvy, that have more manpower resources to get their claims processing clearinghouses up and running and get their codes in the system will be faster. You might see that happen after Q1, whereas, little mom and pop's payer may take a year because they don't have the support staff to help them with this project. And that would be true of any code family changing. It's not specific to ABA codes. And so outlining those questions and making sure you're getting a response from your payers is what this template letter will be aimed at. Yes, I would expect that many payers will rely on, if they're using the Category 3 codes now, they will rely on those codes during the transition period. As I mentioned, many folks will probably choose to do testing of claims behind the scenes while they continue to use the existing code set in the transition period. And again, I can't stress enough. So if you have a payer that is willing to use HCPCS codes, so your H codes, your S codes, there's a variety of codes that people have used over the years to pay you for those indirect services, it doesn't mean that they can't supplement this new code set with HCPCS codes. So you could see a scenario where the payer implements the new codes, but they keep H0032, for instance, and they tell you in their payer policy and in your contract, this is how you report that treatment planning time. So if you've got that negotiated, that doesn't mean that has to go away.
Okay, great. Another question is, some of the folks have mentioned that they've seen providers or payers, misinterpret the MUE of 8 hours a day to include therapy, supervision, and parent training so that no child gets 40 hours a week. And how would you recommend fixing that so that it doesn't cause confusion among payers? And have you seen that as well?
I have not heard that specific issue. No, that's very helpful to know. I would say that I'd be more than happy to chat with those folks, and we could certainly supply them with the letter that we sent to CMS that resulted in the changes. I think it pretty clearly carves out what each service is intended to represent in those caps. So that would probably be, and then CMS's response letter to us would probably be helpful to present to that particular payer to show them maybe they're a little off track.
Okay, wonderful. And then one of the other questions we're coming into is when negotiating rates, how do you consider some of the codes could be billed by an individual but also concurrently? So historically, how do you kind of deal with that negotiation when that rate could be a little different?
I think I'm a little confused by that question. Would it be possible to give me an example?
Sure. Let me ask the respondent to give an example. So if you ask that question, just put it in that chat box there, and I'll represent it. I think the question is probably whether that TRICARE, someone said. I think the question is whether you're able to account for that concurrent billing in the rate versus for maybe a funder who's not allowing that concurrent billing.
So if they took the new codes and after hearing us say and document in different articles and educational resources that the codes are intended to be used together, if they still, via payer policy, decided that they would not allow that, yes, I would certainly be taking into consideration the rates as standalone services and making sure that you're covering the cost of time, because my understanding right now is that TRICARE is requiring a carve out for that QHP direction of technician time. So if in that 3-to-1 scenario, 3-hour session, 1 hour of direction of technician, you'd be billing the 2 hours of direct care and then the 1 hour of direction of technician.
And because you mentioned the QHP, are BC ABAs considered a QHP under the new codes?
Again, up to payer policy, whether they acknowledge and recognize that credential. The same would be true of master's level folks who are enrolled in a program. That's a state scope of practice issue and a payer contracting issue. But under the definition of CPT, yes, they would qualify as a QHP.
Okay, wonderful. And then I am seeing quite a few people saying they've had the same issue with caps on 8 hours of codes. And it looks like some of the examples are they don't want, if they're including cutting out time for SLP and OT, so it makes it more challenging to meet those hours.
Well, that's very strange. Okay. If folks could get me more information about the payers that are at issue, then we certainly can help with that.
Okay, perfect. And then I'm getting a couple questions about the coding conversion chart that you mentioned, Jenna. That's just that crosswalk, correct?
Yes.
Okay, perfect. So for those of you who signed up via our newsletter, it's linked in there, but I'll also send it out after the webinar to all the attendees. And if you're on our Facebook Live, I will link it in the bio as well. Let's see, any other questions? A lot of these questions are very individual, region specific. So
Sure.
I don't know if you want to get in those, Jenna, or if there's more general questions that if you guys have more general questions, so we're not, focusing on like a small region in your state, that might be a better approach. One of the questions I see coming in is it true that a provider or agency must bill the same rate across carriers and patients? And how would that work if some carriers allow us to bill codes concurrently and others don't?
No, that is not true. You are free to set your internal fee schedule as you see fit, and submit whatever amounts you think are appropriate. Now, that doesn't mean that you will be paid what you're submitting. Typically, you would be capped at whatever the contracted rate is. But no, you certainly see a lot of variability between payers and rates.
Okay, perfect. And I do see the funders being named specifically, but because we do have funders in this webinar as well, I'll just pass that along to you, Jenna, after. Okay, and then general question, can you talk a little bit more about the timing of the transition? I know you said that it's going to be so specific based on the size of the carrier and what they're able to do, but is there anything that providers can do to either require them to make the transition? Is there any legalities of how long it'll take them to make that transition?
No, not unless their contract specifically says so, which I would think would be pretty rare. The thing, again, to note in your contracts is what the notice requirement is. So it's really important to know, do they have to tell you in writing? Does it have to be via certified mail? Can an email work? Can a newsletter update that you might never see be formal notice under your contract? And so just making sure that you know what's required on the communication end from them before they make those kinds of changes is really important, so that you're not caught off guard and sort of behind the 8 ball.
Okay, great. And then how about so obviously the codes are for applied behavior analysis, but what about non-autism diagnoses? Does this kind of independent of diagnosis, if they're prescribed to receive ABA, these will apply as well?
Yes, and that's a wonderful question. Thanks to whoever teed that up for us. Yes, it was very important to the steering committee and the broader work group in submitting this application that there is a section in the code change application that asks about appropriate diagnoses for services or procedures. And we were very broad in that approach. These are not autism-only codes. There is a ton of supportive literature out there that these services are beneficial and effective in many other diagnoses. And so, yes, thank you for asking that and clarifying.
Okay, perfect. And let's see. Using the scenario, besides TRICARE, using the scenario discussed earlier, would you agree that we could bill the 97153 for 3 hours and the QHP for 1 hour of supervision at 97155?
Yes.
Great. And what codes would be reported if it's, I know you said you can't, technically the supervision and the report writing, or, if you're in front of the child, you should probably bill the face-to-face. But I think the question is, how would you go about doing that in a way that is ethical? It doesn't really specify in the code. So what would you recommend in that case scenario?
So if you are not delivering a service directly to the child, even though they're present, you should not be coding for that time. So if we're just in the room to meet the face-to-face component, but we're in the room and all we want to do in the room is programming and treatment planning, then that would be a non-billable service. If you're in the room and you are providing that direction of technician, you're engaging, you're modeling, you're telling them how to modify whatever trials they're running, that's true direction of technician, and that would be a reportable service.
Okay, great. And when do you anticipate the MUEs for the new codes will be available? And I apologize if you answered this already as I was fielding questions.
I am not exactly sure what to expect. They reissue those, I believe, twice a year, January and October, I believe. So I wouldn't expect them in October, although I can certainly reach out and ask, and that's a great question. We can include that in our next correspondence.
Great. And some clarification on the program modification part. I think the additional question is, so then what is program modification? Both direction of technician and program modification are written in the 97155 code.
I'm just reading. So it's protocol modification, right? And it's requiring that it be delivered and administered by the QHP. So I think that is intended to be, and you'll have to give me some grace here. I'm a lawyer, not a BCBA. So my understanding is that the intent of that is the hands-on, literally jumping into the chair across from the child, modeling for that technician what you're wanting them to be doing, or as the technician is in the seat, verbally instructing them and guiding them on what you're wanting to see. It's not the actual writing or changing of the words or the goals in the program. It's the delivery of that modified information that you've already done back at your desk at some other time or wherever you did it, and actually implementing that, assisting the technician and educating them on how to do that.
Yeah, I think that there's probably still going to be some confusion about this topic, but I'm hoping for those of you who haven't signed up for the APBA webinar, I'm hoping maybe we can take some of these questions and Jenna can dig a little deeper, maybe the second or third round. So for those of you who aren't aware, there's multiple multiple presentations like this that the different professional organizations are offering. So please join those if we don't get to your question. Let's see, one of the other questions that we are coming into is related to age groups. So what about the under 3 services? Do these codes relate to early, the 0 to 3 as well, or is it specific to school age?
These codes are not limited by diagnoses, age, they are intended for these services provided to whomever they're being provided to.
Okay. Yeah, and there was actually an example from California and from Massachusetts about this, about how the Department of Public Health kind of says that they're the payer of last resort, so they kind of have no knowledge about the codes or wanting to fund for that age group.
Okay.
So I think those are the examples. So I think what I'm hearing is that that's probably something that they should talk to their local chapter about to get additional clarification about the legalities of that.
Yeah, absolutely. I mean, that's a great opportunity for education. Obviously, we know that the literature is highly supportive of these services, particularly in a very young population. So, yeah, I think that's a great opportunity to have a meeting and put some of that data in front of folks.
Perfect. And then for APBA, are you going to be presenting the same presentation, or is it going to be an adjustment to what you've done for us here?
Yes, I will correct my slides so that the code numbers are the real code numbers. And actually, Sarah, I'll do that right after we hang up so that you can post the correct codes as well.
Perfect.
But, yes, they will be virtually the same, and that's intentional so that we're providing consistent information across all the different organizations that wanted to host this topic. I do know that Gina Green will be working with me on the APBA webinar, and so that'll be wonderful to have that clinical bend as well to answer some of these more technical questions.
Wonderful. And what I think we'd love to do is have you back maybe in a month after everyone's gotten additional information, and see if there's particular areas that we could have you present on a little differently, in a month or two.
Sure.
So wonderful. Okay, so then let's see if we have about 15 more minutes, and I see a lot of additional questions coming in. We kind of touched on this a little bit, but I want to get some clarification on it related to the location of services. Can you talk a little bit about any restrictions related to location, whether school or community or center, things like that?
Sure. So the codes themselves do not dictate where they can be delivered. I will say that with the remaining Category 3 codes, we do have that customized environment. So we would have to make sure that we can customize an environment, whether we're at home or in a center or in the community, depending on what that means for that particular individual. But beyond that, no, CPT does not speak to site of service or develop site of service specific codes. That would be a payer policy issue. And obviously schools is the really complex one. If you are in an area and fortunate enough that schools have sort of gotten to the place where they do have a collaborative model and ABA can be provided in the school setting, that's wonderful. A lot of places that's not the case quite yet. We're sort of working towards that goal. So those would be important legal issues within your state to know, and probably guided by some scope of practice as well.
Okay, perfect. There's some questions about where to buy the book and things like that. Just know that we'll send out a follow-up email to all the attendees with all the pertinent links so that you can do that. And if you're in the ABA Business, the ABA Business Builder group on Facebook, then we have linked that there as well. Okay, let's see. Any additional questions coming in? Some of these are just related to where to find resources. So again,
Okay.
I will send those, or Jenna and I will get together and figure out what to send. There's still a couple questions about the 40-hour-a-week caps. It sounds like this is a challenge that a lot of folks are dealing with. The 40-hour cap includes PT, OT, and speech. So I think that's something that we'll have to address as well.
Can we ask a clarifying question about that? Is that truly a MU cap, or is this the therapy caps? I just wonder, with them bundling all those services together and counting it towards one total cap, that sounds to me more like a CMS global therapy cap policy issue than a MU edit issue. Does anyone have any insight on that? Or if you do, shoot me a note. I'm just thinking about why speech and OT would have been bundled in.
Thea is saying they actually subtract any hours at school, get subtracted from a 40-hour request for authorization.
Okay. Well, yeah, having more information about which payers, and I agree, let's not get into specifics on the line. Want to be respectful of everybody's privacy and time, but I am happy to try to support some of those folks that are seeing that trend. I'm really surprised the steering committee hasn't heard this yet. So sounds
Yeah.
like it might be regional.
And it looks like that cap is being used as the reasoning or the, the justification for it by the funders. So, okay, wonderful. Since these codes changed to Category 1, will additional diagnoses besides autism be covered for ABA services? I think we had agreed that yes, that was the case.
I just want to clarify that is the intent. That is our intent. That doesn't mean payers will. So you do, again, payer policy, know your contracts, know your prior auth process. They may decide that they don't feel it's medically necessary for certain populations, and that would be something that, again, I would encourage you to go to the literature and try to do some relationship building and education around why you feel differently.
Okay, great. Any other questions? There's still a couple in the queue, but as I go back, some of them have been answered. So if there's one that I didn't get to, please include it in the chat at the bottom so it repopulates if I overlooked it for some reason. Oh, great. There was a question, thank you for the reminder, about group codes. And I think it was the question of, could you dig a little deeper into it? Because you did go over it a little quickly. And I think the question is, how can you bill it simultaneously? How many people are in the group? There's a couple questions, how do you account for it accordingly in terms of the ratio of BCBA to technician and things like that?
Well, I'll try to address some of those things. Some examples would be wonderful. But also that we have that cap of no more than 8, and that's per technician or per QHP. So if we had a group of 16 people, but we had 2 technicians or 2 QHPs, depending on which of these codes you're reporting in the room, so 1 for each of these sets of 8, that would be acceptable. Does that help?
I don't know if it's just me, Jenna, but you cut out at the beginning of what you were saying. So I wonder if you could just repeat that in case that was the case for our listeners as well.
Sure, apologies. So in regards to group size, the descriptors themselves do say at least 2 in order to have a group. So obviously 1 is not a group. And then in our parentheticals in the book, you will find that there are caps at 8. So we're looking for 2 to 8, whether the technician or the QHP is leading the group. And then as an example, if we had 16 clients, patients in a room, and we had 2 technicians to 16 patients or 2 QHPs to 16 patients, in that case, obviously, it would be acceptable to report the code for the 2 groups of 8 because you have enough healthcare professionals to support that.
Okay, and then you asked for an example, and someone put in that an example for them is that they run a social skills group where they direct the activities of teenagers working together to learn cooking and self-care, and most of the patients have a one-to-one VT present working with them while she, who I'm assuming is the BCBA, leads the group.
Mm-hmm. So in that scenario, I'm not sure why you wouldn't report the one-to-one code because you are staffing them one-to-one. Is there some kind of payer policy that's asking you to instead report? I mean, I understand that you're doing a social activity, but if you're supporting them one-to-one, I think that's still the appropriate way to report the service.
Okay, and I'll look for a clarification on that. What if you're being told no more than 2 hours of group per day by the payer, but the patient may need 4? That sounds like it might be something you might want to take up with the payer directly.
Absolutely. Make sure you've got data to support your medical necessity. I also would double check those MU edits because I'm not 100% what are group codes. I'll be honest, I'm thrilled to hear people are using these codes. In my mind, based on what practitioners share with me, these are some of our lesser utilized or accessed services so far. So making sure those MUs aren't capping you inappropriately too.
Yeah, the clarification was that some funders say if there are peers present, it would be called a social skills group.
Okay. Well, so in that scenario, I can't remember the exact numbers that you gave me. But yes, I think it would be appropriate then to report it. Unfortunately, though, I think you're gonna need to make sure your rate's correct to capture all of the time of all of those folks, because typically, you know, a group rate is quite a bit lower than your one-to-one rates, and if that's supposed to cover all those support staff, that is potentially problematic.
Sure. And the follow-up question to that was that, let's say you have the BCBA supervising multiple technicians that are doing one-to-one work. You know, how would you bill for the BCBA, which child? And my understanding of that is you kind of want to have a clear idea of how much time you're spending with each child during
Yes.
that. You don't want to just say, I'll bill for Johnny on Monday and Jenny on Tuesday. You want to be,
or say that I'm in the room with all of you for the 8 hours, and so I'm going to bill for each person for 8 hours
right.
of directing technician. Obviously, you need to think about what time are you giving to this client, and then this client, and then this client, and parse that out.
Yeah, and if you're using paper and pencil, a lot of that documentation can happen on your treatment notes or data collection sheets as a supervisor. So you should be putting an exact minute count of what you're doing for that child. And if you're online with data collection, I know a lot of the online platforms have a way to do that as well. Can you discuss modifiers? Are there any changes to this? For example, sometimes you can bill for time providing therapy within your center or office at a different rate with a modifier.
So modifiers will be driven by payer policy and contracts. I mentioned earlier that with these codes where it says over here that the QHP could substitute for the technician, that often if the QHP is substituting for the technician, then you're going to want to use a modifier if the payer requires it / accepts it to get that rate differential for a higher level service provider. But again, that's going to be something, if you want to be using modifiers to distinguish between staff levels, something you should ask about as you're entering into contracts. And then certainly you should know whatever you've already executed if they require it. I'm sure it will be brought to your attention if they do, because you'll have some denials.
Okay, wonderful. Let's see. Oh, great. Thank you, Thea. There was a clarification for the session notes I was talking about, that it may be funder specific. So thank you for bringing that up. Another question is whether the Q&A will be included in the webinar. We are live on Facebook. So yes, the Q&A is live on there, and it will also be on the video that we place on our website. So the Q&A will be included on here. Another question about concurrent billing. I think we've covered it mostly, so I'm going to skip over it, but there's a second part just relating to the QHP, and I think it sounds like there's still some confusion about who's constituting, who is the QHP, what's the qualifications of them, and how do you make sure that you're in compliance there? What are the definitions of a QHP?
So again, that's where having our code book is really important, so that we have the specific definition from the CPT panel and the AMA. I will work with you, Sarah, to get the exact, I'm looking through my document right here. I know it's in here, but I don't want to waste people's time. So we'll make sure that we get the exact terminology out to folks. But truly, regardless of what the AMA definition is, that is going to be driven by your state scope of practice laws. So you really need to know what they're going to recognize and what levels of service providers are allowed.
Okay, wonderful. Great. Well, we're coming up on the 30-minute mark. So Jenna, I just wanted to provide my sincerest thank you again for spending the last 90 minutes with us. I know everyone here is so appreciative of all the hard work you've been doing on this. I think, everyone is putting in the chat how appreciative they are and how thankful they are. So thank you very much. And I know that we definitely would love to have you back for additional clarifications. Again, please everyone give Jenna some time to respond to questions, and she and I will work together to put together an email a couple days, maybe a week after this presentation, to send to everyone so that everyone has some answers to these questions. Jenna, do you have anything you'd like to close with?
No, I just want to say thank you so much for your time and attention. I know this is a big chunk in the middle of the day for folks, and so I'm very appreciative of you devoting that to spending some time with me, and thank you for the wonderful questions. I think there's a lot of savvy folks out there who are really intuitive and asking very helpful questions that help educate everyone. So thank you for your engagement.
All right, thank you everyone. Have a wonderful Friday and a wonderful weekend, and we'll see you hopefully next month at our next webinar.